Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we'll continue with the brainstem strokes. We'll discuss Pontine syndromes, horizontal gaze palsy and seventh nerve palsy. So today we'll discuss Pontine syndromes. What is Pons? Pons is actually a bridge. Pons is a bridge between the two cerebellar hemispheres. So the pons is the connecting organ which looks like a bridge connecting the two cerebellar hemispheres. So in Pons, basically we have the pontocerebellar fibers which forms a bridge between the two cerebellar hemispheres. So the bulk of the Pons contains these massive fibers, the pontocerebellar fibers, which gives lot of information to the cerebellum. We also have the corticospinal fibers, a lesion of which will cause hemiplegia. Then the other tracts are the medial lemniscus, medial longitudinal fasciculus, spinothalamic tract. But what we need to understand here is that the pons can be divided into an inferior section and a superior section. Basically, the inferior sections contains nerves other than the fifth nerve, that is the sixth nerve, which is the medial most, followed by seventh nerve and then the eighth nerve. So we have fifth nerve, we have sixth nerve, seventh nerve and the eighth nerve. Once we go to the superior section of the pons, we get the fifth nerve. So the superior section of the pons will have the fifth nerve, whereas the inferior section of the pons will have the sixth nerve, seventh nerve and eighth nerve. Sixth nerve is the medial most, lateral to it is the seventh nerve, and still lateral to it is the eighth nerve. We have two important syndromes in the pons, namely the Fowle syndrome and the Milliard-Gubler syndrome. Fowle syndrome is a horizontal gaze palsy. It is not just one movement, it is a gaze palsy, that is medial rectus on one side and lateral rectus on the other side. So Fowle syndrome is a horizontal gaze palsy with seventh nerve lesion, ipsilateral seventh nerve, element type of seventh nerve palsy and hemiplegia. It is a dorsal pontine injury. Whereas Milliard-Gubler syndrome is a ventral pontine syndrome wherein there is only sixth nerve involvement, lateral rectus. Unlike Fowle's, where there is horizontal gaze palsy, in Milliard-Gubler there is only lateral rectus palsy with ipsilateral element seventh nerve palsy and contralateral hemiplegia. So to understand these 2 points, important points, namely what is this element seventh nerve palsy and what is this horizontal gaze palsy, we need to elaborate further and to understand better. So we'll start off with the seventh nerve and then see about the horizontal gaze. Whenever there's a lesion above the midbrain, none of the cranial nerves get usually affected except seventh nerve. Why other cranial nerves do not get affected? Because the cranial nerves are bilaterally innervated. The midbrain has the third and fourth nerves, pons 5, 6, 7, 8, medulla oblongata 9, 10, 11, 12. These cranial nerve nuclei have got bilateral innervation. Not only the corticospinal and corticobulbar fibers on the same side, but also from the opposite side it gets innervated. And therefore when there is a lesion on one side, the cranial nerves do not get affected because they get compensation from the other corticospinal tract. And therefore, in a lesion above midbrain, none of the cranial nerves get affected except seventh nerve. Why only seventh nerve gets affected? We shall see now. I said all the cranial nerves except seventh have got bilateral innervation. Same side corticobulbar fibers and opposite side corticobulbar fibers. But what happens to the seventh nerve? Why is this peculiarity in the seventh nerve? Seventh nerve nucleus has got upper part and the lower part. Remember the seventh nerve is in the pons. Seventh nerve nucleus has got upper part and the lower part. Upper part supplies the upper part of the face and the lower part supplies the lower part of the face. Like other cranial nerves, the upper part of the facial nerve nucleus has got bilateral innervation. That is the same side corticobulbar fibers and the opposite side corticobulbar fibers. So the upper part has got bilateral innervation, same side as well as the opposite side. But the catch here is that why it is different from other cranial nerves is that why it's a strange manifestation is because the lower part of the facial nerve nucleus gets innervation only from the contralateral corticobulbar fibers. This is the catch. So the lower part of the facial nerve nucleus gets innervation only from the opposite corticobulbar fibers. Likewise, this lower part of the facial nerve nucleus gets innervation from only the opposite corticobulbar fibers. So what is UMN lesion? Anything above the nucleus is UMN, anything below the nucleus is LMN. So what happens in a UMN lesion? Example on the right side, the upper part of the seventh nerve nucleus fibers gets affected, but this gets compensated from the opposite side. Again the fiber supplying the opposite upper part gets affected, but again this upper part gets compensated by the ipsilateral corticobulbar fibers. So when there is a right UMN lesion that is above the nucleus, finally only the lower part of the facial nerve nuclei on the opposite side gets affected. So when there is a right upper motor neuron lesion of the seventh nerve, the left lower half of the facial nerve nucleus, that is the nucleus on the opposite side, and that too the lower part only gets affected. Lower parts supplies the lower part of the face, and hence the lower part gets affected. So when there is a right UMN lesion, the left lower half of the facial nerve nucleus gets affected. The lower part supplies the lower part of the face, and therefore when there is a right UMN facial lesion, there is a lower half of the face gets affected, and that too on the opposite side. So any lesion above the midbrain, there would be left hemiplegia and left lower half of the face gets affected. So the angle of the mouth will deviate towards the healthy side, right side. But if it is an LMN lesion, like a Pontine lesion, so if there is a lesion here in the pons, like it could be Fovile syndrome or it could be Milliard-Gubler syndrome, when the seventh nerve nucleus per se gets affected or the seventh nerve gets affected, it's a final pathway. So both the upper part and the lower part on the same side gets affected. So ipsilateral facial palsy, there will be upper part and the lower part on the same side gets affected. So any lesion above the pons will affect only the lower part on the opposite side, whereas a lesion in the pons, or as the seventh nerve nucleus has a seventh nerve descends, the same side, both the upper part and the lower part gets affected. So we call that as ipsilateral seventh nerve palsy. Right. Now we have understood this seventh nerve palsy, UMN LMN type. Now let's see the horizontal gaze. I said in the early part of my lecture, in Fovile syndrome, which is a dorsal Pontine injury, horizontal gaze gets affected. Whereas a Milliard-Gubler syndrome, where there is a ventral Pontine injury, only the sixth nerve lateral rectus gets affected. So in Fovile syndrome, horizontal gaze, that is right lateral rectus and left medial rectus gets affected. Whereas in Milliard-Gubler syndrome, only the lateral rectus gets affected. What is this difference? Why is this difference? To understand that, we need to understand the supranuclear pathway subserving the horizontal gaze. So here we go. So we have the eyes. The horizontal gaze center is the PPRF, paramedian pontine reticular formation. The horizontal gaze center is PPRF, paramedian pontine reticular formation. For the vertical gaze, the center is in the midbrain, the rostral part of the midbrain, top of the midbrain, rostral interstitial nucleus of Cajal, rostral interstitial nucleus of MLF, interstitial nucleus of Cajal. All these form the center for vertical gaze. Whereas for horizontal gaze, it is the PPRF, paramedian pontine reticular formation. So this gets supply from the right frontal eye fields area number 8. So right frontal eye fields area number 8 comes and supplies the PPRF. The PPRF connects with the sixth nerve nucleus. The PPRF connects with the sixth nerve nucleus. This is very, very important. We need to pay attention to understand this. Sixth nerve nucleus has got two parts. Sixth nerve nucleus has got two parts. One, the intranuclear abducens palsy. The intranuclear abducens palsy, which supplies the sixth nerve and the lateral rectus. So only if the sixth nerve gets affected or the intranuclear part of the abducens nucleus gets affected, only the lateral rectus gets affected. But the sixth nerve nucleus has also got an internuclear neurons. Not only intranuclear neurons, it has also got internuclear neurons, which goes and crosses over to the opposite side and runs in the medial longitudinal fasciculus to supply the medial rectus. So, sixth nerve nucleus has got two parts. One, the intraneuron supplying the, for example, left sixth nerve nucleus if we take, it has got two parts. One, the intranuclear part supplying the left lateral rectus. Second is the interneurons, abducens neurons, which crosses over to the opposite side, MLF, and supplies the medial rectus. So if sixth nerve nucleus gets affected, both the lateral rectus because of the intraneurons and the medial rectus because of the interneurons get affected. So they will have horizontal gaze palsy. So if PPRF on left side gets affected, the eyes cannot move to the left side. The eyes will move towards the opposite side. Whereas if the sixth nerve fascicle gets affected, only the lateral rectus gets affected. So in Milliard-Gubler syndrome, only the lateral rectus, the fascicle gets affected, whereas in the Fovile syndrome, the sixth nerve nucleus gets affected and therefore horizontal gaze gets affected. Again here there is a very important point. Since PPRF pulls eyes towards its side, when there is a lesion in the pons and the PPRF, it cannot pull the eyes to its side and therefore eyes will go towards the opposite side. And since the corticospinal tract descends in the pons to the medulla and crosses at the level of the medulla and goes to the opposite side, when the PPRF or the pons gets affected, eyes cannot be pulled towards its side. Eyes will move towards the opposite side. Hemiplegia is also on the opposite side. So eyes will look towards the side of hemiplegia in a pontine lesion. So in a pontine lesion, when there is a PPRF lesion, eyes will look towards the side of hemiplegia. Whereas if we take the frontal cortex, frontal eye fields area number 8, the fibers come, descend and go to the PPRF on the opposite side. So PPRF connects sixth nerve on the same side with the third nerve on the opposite side. So eyes will be pushed to the opposite side. So in the right frontal cortex, frontal eye fields number 8, eyes will be pushed towards the opposite side. So when the frontal cortex gets affected, eyes will be pulled towards the same side. Hemiplegia will be on the opposite side. So eyes looking to one side and hemiplegia on the opposite side, the lesion is in the pons. The lesion is in the frontal lobe. Eyes looking towards the side of hemiplegia, the lesion is in the pons. So very, very important point. Another important point is about the oculocephalic reflex, OCR. The medial longitudinal fasciculus connects the third nerve, fourth nerve, sixth nerve with the eighth nerve nucleus, vestibular nucleus. So the vestibular nucleus goes and gets connected to the sixth nerve nucleus. So imagine my right side vestibular nucleus goes and gets connected to the opposite sixth nerve nucleus. So when I turn my head towards the opposite side, my right vestibular nucleus gets stimulated. It stimulates the sixth nerve on the opposite side. Sixth nerve has got both inter and intraneurons. So left lateral rectus and right medial rectus get stimulated. So eyes will move towards the opposite side. This is known as oculocephalic reflex. So when I turn my head towards the right side, my right vestibular nucleus gets stimulated. It connects the sixth nerve nucleus on the opposite side. Sixth nerve nucleus is responsible for horizontal gaze through inter and intraneurons, and eyes will move towards the opposite side. So when my right vestibular, when I turn my head to the right side, the eyes will move towards the left side. So when there is a PPRF lesion, paramedian pontine reticular formation, PPRF also will pull the eyes towards its side. Sixth nerve nucleus also will pull the eyes towards its side, because PPRF acts with the muscles through the sixth nerve nucleus. So how do we differentiate PPRF lesion from a sixth nerve nucleus? So when the vestibular stimulation, if the eyes are able to go towards the opposite side, it's a supranuclear palsy, that is a PPRF palsy. So parapontine reticular formation lesion can be overcome by oculocephalic reflex. Whereas if the sixth nerve nucleus per se gets affected, it is element type of ocular motor injury, and therefore it cannot be overcome or it cannot be stimulated by oculocephalic reflex. So by oculocephalic reflex, that is, if I turn my head towards the right side, if I can move my eyes to the left side, voluntarily if I am not able to move, but if I turn my head towards the opposite side, right side, and if my eyes are able to move to the left side, it is a supranuclear palsy, that is a PPRF lesion. Whereas when I turn my head to the right side, still I am not able to move my eyes to the left side, it is an element type of, or a nuclear or intranuclear type of palsy, that is a sixth nerve nuclear palsy. So these are very important points. Another important point is that we have PPRF on this side and the other side also. So when both the PPRF gets affected, the horizontal gaze to its side and this side also gets affected. So the entire horizontal eye movement gets affected. So if there's a lesion in the pons, the entire horizontal eye movements are affected, and both the corticospinal tracts are affected. So both the upper limbs and the lower limbs get affected, and the entire horizontal eye movement gets affected. But midbrain is intact. As I said, midbrain is responsible for vertical eye movement, and therefore the only movement possible is vertical eye movements. So this is known as locked-in syndrome. So locked-in syndrome is a syndrome wherein there's a pontine injury dissecting both the PPRFs and both the corticospinal fibers. Since both the PPRFs are affected, they cannot move eyes horizontally. Because both the corticospinal fibers are affected, they cannot use the upper limbs or lower limbs. But since midbrain is intact, they can move eyes up and down. So only movement possible is up and down eye movement. So this is known as locked-in syndrome. And another syndrome is that if PPRF gets affected, imagine left PPRF, the left lateral rectus and the right medial rectus gets affected. So one movement is gone. And if there is another MLF lesion on the same side, adjoining MLF lesion, the adduction also goes off. So if PPRF gets affected, if left PPRF gets affected, left lateral rectus and right medial rectus movement is affected. If MLF is affected, left adduction gets affected. So one movement, half movement is affected, and only movement, half movement is possible is the right lateral rectus. And that too there is nystagmus because of Herring's law of equal innervation, wherein the yoke muscles gets equal innervation. So when my left medial rectus is not able to move, there are extra impulses, compensatory impulses coming through the supranuclear pathways trying to move the right lateral rectus, so you get abducting nystagmus. So this is known as 1.5 syndrome. So 1.5 syndrome is a syndrome wherein there is a lesion of both PPRF and MLF. Because of PPRF, one movement is gone. Because of MLF, half movement is gone. The only half movement present is the abducting nystagmus. So this is known as 1.5 syndrome, wherein one movement and half movements are gone. Along with the PPRF and MLF, the sixth nerve also gets affected. So facial nerve, seventh nerve is also gone. 1.5 movements are also gone. So we call that as 8.5 movements. So 1.5 syndrome, this is known as 8.5 syndrome, if the seventh nerve also gets affected. Right. Now, as I said, there's a lot of difference between the sixth nucleus involvement and sixth nerve involvement. If the sixth nucleus gets affected, both the intranuclear and the internuclear neurons get affected, and therefore there's a horizontal gaze palsy. Whereas if it's a fascicle gets affected, only the lateral rectus gets affected. So Fovile syndrome is a dorsal pontine injury where there is a horizontal gaze palsy, ipsilateral facial palsy, and contralateral hemiplegia. The PPRF is the sixth nerve nucleus gets affected, so there is a horizontal gaze palsy. The corticospinal fibers affected, so there is hemiplegia. Seventh nerve is also affected. Whereas in Milliard-Gubler syndrome, ipsilateral seventh nerve palsy and contralateral hemiplegia, but there is no horizontal gaze palsy. It's only sixth nerve, that is lateral rectus palsy, and it is because of ventral pontine injury. And another point, as I said, how do we differentiate between PPRF and sixth nerve nucleus? If there is a supranuclear eye movement palsy, voluntarily they cannot move. But on vestibular stimulation, if I am able to move the eyes towards the opposite side, that means the lesion is in the PPRF. If even on vestibular stimulation, if I am not able to push the eyes towards the opposite side, it's a sixth nerve nucleus. So to understand all these important points, seventh nerve palsy, horizontal gaze palsy, and the pontocerebellar fibers, we need to understand all these points. So this is an overview of Pontine syndromes, horizontal gaze palsy, and seventh nerve palsy. I've enjoyed giving this lecture, and I hope you have also enjoyed listening to this lecture. If you have any suggestions or comments, kindly post to my YouTube channel. Please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.